think we're here today to try and inform as many veterans as we can. We're here with Dr. Bash.
Welcome, Radio Land, TV Land, and YouTube viewers and listeners. This is Dr. Craig Bash. I've been doing veterans medical opinions for 30 years, and I have dozens and dozens of these radio shows which we're going to publish on this YouTube channel, and number 1 through whatever. So thank you for listening, and here we go.
How you doing today, Dr. Bash?
I'm doing good. We got a couple updates for you.
Well,
we've got a
good
couple
deal.
new law things, maybe, and I've got something on CMP exams. So the guy last week that had like 7 days notice for a CMP exam, right? And
Yes.
so he wanted me to get a letter for him and a DBQ. So I did that real quick in a couple days, and he tried to upload the new stuff into the e-benefits before the CMP exam, and the e-benefits was blocked. It was blocked for new information. So the VA was trying to not allow any new information before the CMP exam. So what we did is I had him fax it, use the VA fax number for the intake center to try and get my stuff in before the CMP exam. So if anybody runs into that problem out there, if you're getting blocked for your e-benefits, adding new information, use the VA fax numbers.
Okay, that's good to know. Thanks for that.
Bill,
I think maybe to add to that, you should probably follow up with a call, confirm receipt, and at least make it part of the record that you asked that benefits counselor to see to it that the examiner reviews your evidence before the exam.
Oh, there you go.
Won't guarantee it's going to happen, but at least you document the fact that you had it, that you turned it in, and that you wanted it considered.
Yes,
yeah.
That's important too. I don't care what you do with the VA, you need some sort of documentation or registration or, a claim number or something, a case number or anything. You can get a confirmation number maybe, something there that you did make the effort and the material was there.
Hey, Bill, what was some new thing about the cardiac law you talked about, huh?
Oh, yeah, this month VA has revised the rating schedule. That portion dealing with the cardiovascular disease. I think it's basically an effort probably best described as simplification. I think what their VA's rating schedule, of course, dates back generations, and legal terminology evolves over time, and understanding improves over time. And so VA from time to time revises the rating schedule to have it reflect the current terminologies and perhaps the understandings that have evolved in the interim. So I think they've done the same thing to the heart, and the old version of the rating schedule had a lot of diagnostic codes. And, it could be one for arrhythmia, could be one for enlarged heart, this even blood pressure. So what VA has done for evaluating the cardiovascular system, they're taking all these criteria from all these different diagnostic codes and consolidating it into just a few. And the way that VA has evaluated the severity of heart disease in the past included more variables than it does in the new version. For example, a condition like hypertensive heart disease that results in limitation of METs, that is the way they measure the fitness of the heart, so to speak. It also had a provision where, regardless of the METs, if you had an ejection fraction between 30 to 50%, the evaluation was 60. So you didn't need the METs if you had the ejection fraction. You could rate it that way instead. Well, what's happening now is they're taking out the alternatives and they're evaluating everything, well, nearly everything, on just the METs, none of the other. Now, it requires that you take the stress test and have the METs measured. And then the evaluation of the heart will be assigned in accordance with what the METs are reported as being on the stress test. Exception is, and this is not new, but the exception is if a doctor says you cannot perform a stress test, then the obligation is for the VA examiner to do an interview and estimate the stress test. Basically, they'll talk to you about, are you able to mow the lawn? Can you climb a flight of stairs? Some other activities that describe when you run out of breath, get dizzy or fatigued, or the typical symptoms if your heart's not working good enough, you're running out of energy. What level of activity will bring on those symptoms, and then the VA, the evaluator, the rater, can use that METS estimate in lieu of the METS test. It's probably going to be a result in what I said before, simplification. So it'll be easier for the raters to pick an evaluation because they don't have to consider multiple criteria anymore. So that's, I'm not sure if that's a good thing or a bad thing, but sometimes it would help. If I was rating a heart case and I had evidence that was inconsistent or METs that, you kind of scratch your head and you're wondering, well, now wait a minute, how did he get that when, he's telling me the METs is, says he measures METs is, but the guy's a double amputee, so how did he do that? You get posed with these kinds of questions that brings one part of the exam into question. Well, if I look at an ejection fraction, and the ejection fraction would give me the alternative where I can give him 100%, I can just go ahead and give him the 100%, and the heck with the rest of the exam. Now that option will be gone. Instead, it's just strictly going to be on the METs for everybody. And that's...
Bill,
yeah.
On that MET test, someone has a heart condition, and their heart specialist, would write them a letter stating that they're not physically able to conduct a METS test, then that should be good enough right there, wouldn't it?
Yes. That's good enough to say he doesn't have to do the METS test, and instead the rating activity now requires a METS estimate by the doctor.
I think I will call a lawsuit.
The reason I bring that up, because on my last CMP, the doctor mentioned to me that he couldn't find anywhere in my records where it said I had ischemic heart disease. And of course, that's due to exposure to herbicides. And he said, so I don't know what I could do for you on your heart, although I remember seeing it in my records, but there's so much stuff in my records it'd be easy for a doctor to overlook. And I feel like I'm going to have some repercussions over that, because it's certainly something I will fight them over. And with this new policy, next time I go to my heart specialist, I'll have him write me a letter, which I'm sure he will. He's already written me one. But
absolutely.
with
Absolutely.
yourself.
Get the letter from your doctor saying this is ischemic heart disease.
Mm-hmm.
But that's not the only alternative. Understand, I've mentioned this before in the past. There is the practice of medicine for treatment, for care, okay? And the practitioners and the physicians and the researchers develop a common language where words have specific meaning in that context. In VA, we have what I refer to as VA adjudication medicine. Okay, couple of adjectives for that, because there are terms that VA uses that aren't used in medicine, or terms in medicine that aren't used in VA, that create a conflict between what is understood between the medical side of the house versus the adjudication side of the house.
Right.
One example of that, and Dr. Bash and I are going to talk about this further later in the exam portion, but if you look at the current DBQ for a spine and you look at the rating schedule, they contain the same language. And under 5243 diagnostic code of the spine, they talk about intervertebral disc syndrome, and the evaluation criteria is how many weeks the doctor has ordered you to bed rest. Okay? Two problems with that. One is the medical world no longer uses the term intervertebral disc syndrome, so doctors are naturally inclined to check the block no. And secondly, the manifestations from disc disease are not typically treated with weeks of bed rest anymore. Okay? So the criteria established by VA back in 2003 for evaluating this disorder is using an obsolete diagnostic word and obsolete criteria. So basically, VA examiners, and I've seen other examiners doing it as well, they check the box no because they don't use intervertebral disc syndrome, and they check bed rest no. Well, of course he hasn't. They don't do that anymore. So you don't get any money for intervertebral disc syndrome or your disc pathologies. And here,
60%.
What's that?
Yeah, the max is 60, but in practical purposes, you don't see very many people doing it because people are not ordered to bed rest for that long of a period of time. So in practical sense, let me say this. I wasn't able to grant 60% under that criteria because I never once saw evidence that a veteran was ordered to bed rest for a period in excess of what would be required for 60%. So, if you have the wrong diagnostic words and the wrong criteria, you don't get compensated. But the flip side of that coin, and I'll just, before I get back to what I started on, I'll just say that when the revision was made in 2003, VA made clear that you rate neurological manifestations separate from orthopedic. So if you're measuring orthopedic, you're doing range of motion. So everybody gets 10, 20, 40% for their what's now called the thoracolumbar spine. Mm-hmm. Then, if you have radiculopathy, you're getting radiating pain into the buttocks, down the leg, you're getting numbness, tingling, maybe even most severe cases, you're starting to develop a foot drop because you're losing control of your foot. Okay? Those manifestations are rated separate. So it's not uncommon for somebody who has this severe disc disease to have a 20% for his range of motion and a pair of 20% for each leg, okay? Yep. Because they are being affected. So you get to your 60 or even 70% with those radiculopathies added in, or any others like bowel or bladder disturbance. Okay, so that's what I wanted to make clear. But when it comes to qualifying diseases associated with herbicide exposure, VA has redefined the medical term ischemic heart disease to mean other things, such as myocardial infarction, which we know is a clot, okay? Atherosclerotic cardiovascular disease, or hardening of the arteries, you see?
Oh.
So the examiner is thinking, wait, I'm looking for something that diagnosed ischemic heart disease, and I don't see it here. I see hypertensive heart disease, I see atherosclerotic heart disease, I see myocardial infarction, but I don't see the words ischemic heart disease. Well, VA put those other words into the manual so that everyone would know that these common cardiovascular diseases are what VA intends to include in the term ischemic heart disease. And so we shouldn't, I actually had this question come from a rater who came to ask me about that. What can I do? The doctor didn't find ischemic heart disease. I said, well, here, look in the manual. These are the terms that VA, for rating purposes, accepts to establish the presence of ischemic heart disease. Look on that list. Okay, and there it is.
Okay. So even though the CMP examiner mentioned it to me like that, I had already produced a letter stating I had hardening of the arteries and aortic stenosis. So that should have covered that, wouldn't it?
Let me say it should.
It'll cover.
Okay.
It'll cover on.
You know,
Yeah, it'll cover on your atherosclerosis, but don't be surprised. The aortic stenosis in itself is actually more of a valve problem than it is ischemic.
Well, yeah,
And,
it is a valve problem.
And they say that's kind of more, that's more hereditary than anything else. So I've already been down that road.
Well, the hard plaque build up in my legs and stuff.
But now here's how I used to resolve that debate. Okay, now we're looking at a disease, and we're saying to ourselves, okay, there's a genetic component here, there's a valvular disorder, and he also has one from the list of service-connected presumptive conditions for the heart. Right. Now, if I don't see the answer to that in the record, okay, then the manual instructs to ask the doctor to explain and to say, can you determine how much of disability results from each? Can you apportion a degree of disability between them? In my experience, that's going to be real hard to do. In accordance with the benefit of the doubt requirement, if you cannot determine what degree to apportion between the service-connected versus non-service-connected condition, then you must attribute all manifestations to the service-connected condition. That's the rule.
We have a caller in here. We have a caller in here. Let me try to bring them in.
I got it, Joe.
Caller, 404 area code. You have a question or comment? Oh, they left. Oh, okay. I guess not. Go ahead. Go ahead,
Well,
Bill.
let's hope he got the answer. Let's hope he got the answer to the question while he was waiting.
Yeah.
So, Bill, back to those meths. They're like a measure of oxygen consumption. So, like if we talked about guys that are paralyzed or amputees, they can have heart disease, and So in those cases, since they're not going to be able to do much in the way of the Met, and they might not be able to really measure things like walking and mowing the grass and so on, you think the VA will go back to some of the older things like arrhythmias and heart size to help, like if it went to central office maybe or something?
No, at this time, this month, VA has stepped away from rating them on alternative bases and consolidating them. Now, I'm making a very broad explanation here, and for each case, you look at the diagnosis present and compare that to the new criteria, the rating schedule, and see which way helps the veteran the most.
Mm-hmm.
At least that's what we're supposed to be doing. Okay. Now, the thing is that this is going to speed the adjudication because there are fewer criteria for the rater to explore, and the rating software. I explained before that it's not totally an exercise of judgment involved here on the part of the rater. When the rater transposes the data from the DBQ into the software, that software creates the evaluation. So it's not like the rater is sitting there, well, yeah, this guy's got so many Mets, but he also, he doesn't seem to be well able to overcome them, so maybe it more nearly approximates 60 instead of 30. Okay? That's not the process. The rater takes the data, the Mets, off the DBQ, puts it in the computer, and the computer says, this is 30. Okay? Are there opportunities for overrides? Yes, there are. But nobody wants their work reviewed by central office because they're afraid they'll be criticized and found in error and lose their job or whatever.
So if the patient can't, if they can't do the Mets, then say for example, I give them a Met of 3, and the VA doctor gives them a Met of 5 or 10 or something. We'll have that debate amongst experts again, right? Something like that.
Okay, if we're talking about Met estimates, then the rater is required to look at the two estimates and then read what that doctor has to say about how he determined it. And the one with the better explanation is of greater value. Does that make sense? Okay, like if a doctor says, I estimate it to be 3 Mets, and that's all he says. Okay, but the VA examiner says, well, it's 3 Mets because he can't get up from his chair and walk across the room without getting shortness of breath.
Mm-hmm.
Okay, it's 3 Mets. So it's all about how that examiner developed the opinion as to what that Met equivalent is. And that will determine the greater value.
Bill, how would that work?
It's supposed to, okay?
How would a condition like orthostatic hypotension come into play with that, If the veteran's got a weak heart and he stands up and his blood pressure drops over 20 points every time he stands up.
Yeah.
Would that be related anyway?
That's a medical question, but I'd say
Mets of what?
Quite possibly.
Mets of 1 maybe.
Yeah.
Might be a Met of 1. Right, Bill's got to go to the Mets, right? You said you don't really take the diagnosis.
Well, the thing is that the 100% evaluation kicks in at 3. So we don't, for rating purposes, if it's 3 or less, okay, if it's 3.1, it's 60%. But if it's 3 or less, it's 100%.
Now, how do they actually do the measurements for the Met? Because I've always been under understanding and working with other people with heart casts in the lab and things like that, if you have a cardiac catheterization or echo, and they want to actually measure your heart function, the actual golden rule for this is the ejection fraction. So I don't see how they're getting away with going around that. And
they're taking it out.
Mets have to do.
Yeah, they're taking it out.
Consumption.
It
I
used
hate
to
to say
be,
that, but that's probably going to be challenged in court, and they're going to lose.
huh? Might be a fun
They're
debate
probably
to
going
have.
to be.
Yeah.
They're going to be challenged in court, and they're probably going to lose because the gold standard is the ejection fraction. That's what the cardiologists use to actually determine the strength of your heart.
Remember I said earlier, there is medicine for treatment and care in the medical community, and then there is VA adjudication medicine.
Yep.
Okay?
So
In
Bill,
VA adjudication medicine, for rating purposes, up until this month, a ejection fraction less than 30% was 100%. An ejection fraction between 30 and 50 was 60%.
Okay? That's true.
And so now they're taking that out. And they're going,
so Bill, this is a manual change, right? It's not a Congress change.
this is a regulatory change.
Really? All right.
Yeah.
They're supposed to set in the Federal Register.
Yeah, that's the 38 CFR, Part 4, of course. 4.104 is the evaluation for cardiovascular disease.
Thank you all for listening. That ends this show. And now I'm going to zoom off.